and this aortic dissection is a sudden presentation, and this aortic aneurysm is not as sudden, but it's kind of asymptomatic, although it can produce few symptoms which are not that relevant or non-specific to this aortic aneurysm. So if there is a smoker, hypertensive, walks into your clinic, 65-year-old, and then for some reasons you did a CT and you found a dilated vessel, dilated aorta, that is aortic aneurysm. And such aortic dissection patients won't come to a clinic. They're definitely going to present in an emergency department. So let's just take a look at the aortic aneurysm. Aortic aneurysm, it can be in abdominal aorta or it can be in the thoracic aorta. So it presents with similar features. So there is going to be a pulsatile mass. This is going to be in the abdomen, and it can lead to belly pain or abdominal back pain. Okay, and in such cases we can also see some discoloration on the skin, which is called as the flank ecchymosis, due to some leakage of blood in the retroperitoneum. Okay, and this thoracic aorta can present with some other non-specific features, like it can compress over the trachea and it can lead to stridor. It can compress over the recurrent laryngeal nerve and lead to hoarseness, and it can also compress over the esophagus, leading to dysphagia. See, these symptoms can be present in many conditions relevant to thorax. So these are not that specific to these. So what you do is we need to, learn how to investigate and how to go for surveillance of such patients. See, in what kind of patients, you need to ask yourself a question. What kind of patient needs a screening for aortic aneurysm? Definitely those who are at higher risk of formation of aortic aneurysm. And who are those patients? So any male who is above the age of 65 and smokes, he's at risk of aortic aneurysm. So screen him with an ultrasound. Other patient who has a family history of aortic aneurysm and is more than 65, again screen him. Or if the patient has Marfan's, because Marfan's have some connective tissue disorder which leads to weak vessels, or there is some known aneurysm in other parts of the body, so just go for abdominal ultrasound to just check for any kind of aneurysm. Next is, if you find an aneurysm, how will you diagnose? So if the diameter of the aorta comes out to be more than 1.5 times the normal value or more than 3 centimeter, you call it as an aortic aneurysm, and you have proper guidelines on how to go for surveillance of such cases. See, there have been different guidelines over RSEGP or in a Red Book or in some other places of Australian sources. So the one that we have agreed upon and one that eMedici follows is the one that I'm going to tell you now. So if the size is 2.5 to 2.9 centimeter, you need to go for 5 yearly ultrasound. If it is 2.9 to 3, if it is 3 to 3.9, 3 yearly ultrasound. If it is 4, now just it's different in males and females. See, after 4 it gets different. So if it is 4 to 4.5, 4.4 in case of females, or 4 to 4.9 in case of males, you have to go for 1 yearly ultrasound. Or if it is more than 5 in case of males, or more than 4.5 in case of females, you go for 6-monthly ultrasound. And when do you treat it? So there are proper indications when are you going to go for a surgery. And what kind of surgery are we going to do? We are going to just repair our aorta. Either we can go for an endovascular surgery, which is called as EVAR, or we can go for an open surgery, right? And when are we going to perform surgery? See, if the size of the aneurysm is more than 5.5 in males, or if it is more than 5 in case of females, you need to go for surgery. Or if there is an increase of more than 1 centimeter per year, you need to go for surgery. Or if there is an impending rupture, if you perform a CT and there is impending rupture, you go for a surgical repair. And just for the sake of completing this, just remember, open surgeries are done in those who are young, who are fit, and who have a complex anatomy where you can't do endovascular surgery. Endovascular is preferred who is old, not fit, or if a person has suitable anatomy, you can go for endovascular surgery. And when do you go for an urgent repair? What are the conditions where you need to shift the patient to directly to emergency operating room? Or if the patient has a rupture of abdominal aortic aneurysm or any aneurysm, and the person goes into shock, that is, a person is unstable, you shift the patient to emergency and do the ABCs, give fluids and all. Or if there is a rupture on CT, you can't wait for a person to go into shock, right? So you need to shift the patient to operating room and then go for the surgery. And for those patients who are undergoing surveillance, for these are the surveillance timelines, and those who are undergoing surveillance, you need to also put such patients on statins, on antihypertensive, on antiplatelets, and obviously smoking cessation is the most important.